Okay, good morning. I think we are ready to start. So first of all, thank you for the invitation and the opportunity to be with you this morning. My name is Ismail El-Hamamsy. I'm the Director of Aortic Surgery at Mount Sinai Hospital in New York City. And I will speak about the role of the Ross procedure in today's practice and try to give you some insights as to what we do technically to ensure better durability of this operation in the long term. I have no disclosures. For those of you who are less familiar with this operation, the Ross procedure is basically an operation where the principle is to, instead of replacing the diseased aortic valve with an artificial valve, be it a biological or a mechanical valve, what we do is we actually harvest the pulmonary valve and root and implant them on the left side as a root replacement for the aortic valve. So the patient's own native pulmonary valve serves as a replacement for the aortic valve. And then we replace the pulmonary root with a human cadaveric pulmonary root. So it's like a domino operation where the principle is essentially that because the aortic valve is thought to be the most important valve in the heart, we put the most precious substitute in that position, which is the patient's own pulmonary valve, which would allow for better long-term outcomes in these patients. So this is schematically what this looks like. And on the right-hand side of the screen, what you see is a pulmonary valve once it is harvested. The reason why we use the pulmonary is it's a mirror image of a normal aortic valve. It has 3 leaflets like a normal aortic valve does. And because it's autologous and it remains alive, it can perform many of the functions that a normal aortic valve would do. So it's really the only replacement operation that guarantees long-term viability of the aortic valve and the aortic root. Nevertheless, the Ross is not a new operation. It was described over 50 years ago, and it went through different waves of enthusiasm, especially in the 90s here in the US, before dropping off the menu because of concerns with safety of the operation and concerns with durability of the operation. And that's what we will discuss in this presentation. How can we optimize these things? Of course, 40 or 45 minutes is not enough to cover everything that has to do with the Ross. This is a very comprehensive review, which for those of you who are interested, I would invite you to read. It covers everything that has to do with the Ross in a very detailed way, and especially the Ross in adult patients. I will cover 5 points in this presentation to try to convey to you what the role of the Ross is in today's practice and why the Ross is thought to be an option of choice in many adults with aortic valve disease. The first point is that the Ross is associated with improved outcomes versus any alternatives like mechanical or tissue valves. I'll show you some of the data that supports this notion. This is a prospective randomized trial, which we published over 10 years ago now. Young patients, the average age was 38, were randomized to undergo either a Ross procedure or a homograft aortic root replacement. And the average follow-up in this study was 10 years. These were all-comer patients. 8% of them were operated for active endocarditis. Almost half the patients were redo operations, with the most frequent previous operation being a homograft aortic root replacement. So really all-comer patients, lots of redos, lots of endocarditis, not patients that one would think would do very well in the long term. And yet when we looked at their survival 12 years after surgery, as you can see here in the green line, it was exactly identical to the age and sex-matched general population that you can see in black, whereas patients who underwent a homograft aortic root replacement had a significantly lower survival than these patients. So that was really the first study that showed that perhaps when we replace the aortic valve, we can restore survival of the patients in the long term. Now, since then, many other studies, and I won't go too much into the detail of these studies, have shown the exact same signal. This is a study from Toronto in Canada where, as you can see, at 15 years, survival is also exactly identical to the general population. This is a study from Germany that pools many different centers, 10 different centers doing the Ross almost 2,500 patients. And you can see that 25 years after surgery, survival is no different than that of the age and sex matched general population. And additionally, there are studies that compare the Ross procedure to either mechanical or biological aortic valve replacement. This is a study from Australia that compares the Ross to mechanical AVR. And you can see that at 20 years, there's a 10% survival difference between these two groups. This is another study coming from Canada that compares the Ross procedure to tissue AVR. And you can see that at 20 years, there's a significant difference in survival between the two groups. And last, this is a study that compares the Ross to mechanical to tissue AVR. And you can see that the Ross group here has much better survival than tissue or mechanical AVR. And importantly, the survival of the Ross cohort was exactly identical to the age, sex, and race-matched US general population. And there are many more studies in the literature looking at these at this very specific outcome, which is survival, which is a very hard endpoint. It's not easy to say that we have an operation that can restore survival for patients in the long term. The only other operation that we can safely say does so is mitral valve repair. So this is on the aortic side, really the only operation that allows us to say that in patients under the age of 60. Additionally, there are less valve-related complications with the Ross versus prosthetic aortic valve replacement. As you can see here, there are less reinterventions, there's less structural valve degeneration, there's less need for pacemakers, and there are less endocarditis, less stroke or major bleeding. So all of these things are very different between these various groups. And importantly, if you look at the complications related to valves at 30 days, the mortality after a stroke, endocarditis, or major bleeding is much higher than it is with the reoperation. And so while the Ross may not be a forever operation, in fact, none of these operations are forever, but considering the fact that the risk of stroke, endocarditis, and major bleeding is significantly lower with the Ross, when you look at the 30-day mortality that's associated with each of these complications, it becomes very apparent why you would rather have something where the trade-off is reoperation rather than being on blood thinners or having a stroke or endocarditis. So that's with regard to the clinical outcomes of the Ross. And really, these data have become much more apparent in the last 10 to 15 years. Before that, we had a paucity of data with regards to the Ross procedure in adults. It was thought to be, or it was considered to be, an operation that is only appropriate for children because the outcomes were thought to be not so good in adult patients. But as I said, in the last 10 to 15 years, we've had an accumulation of data about the Ross in adult patients, and all of that data converges towards that same signal of restored survival in the long term and less freedom, lower valve-related complications. The second point, however, with the Ross is that unlike aortic valve replacement, it is a technically more challenging operation, as you can easily imagine. We address more than one valve when we do this operation, so volume really does matter. And we don't have data to support so. This is data from the STS database, so covering almost 1,800 hospitals across the country. 800 hospitals across the country. And you can see that there was some enthusiasm for the Ross in the 90s, and then towards the end of the 90s, the operation really dropped off the menu and almost disappeared completely by 2010. And this was really driven by the fact that when you analyze that data, the results were not as good with the Ross as with prosthetic AVR. Why is that? Because there are multiple complexities with the Ross operation. Coronary buttons, you have to be careful about coronary arteries that you can injure, the LAD or the first septal. Harvesting the pulmonary valve can be tricky or challenging. There can be issues with annular mismatch. Myocardial protection, as all of you are well aware, is also an issue, especially in operations like these that are much longer. And bleeding, of course, is another consideration in an operation that requires so much dissection and so many suture lines and longer bypass runs. And if you look at the STS database, this is a study that's now almost 10 years old, but they compared the Ross procedure to conventional aortic valve replacement. And what they showed was a mortality rate that was 3 times higher with the Ross than with conventional AVR at 2.7% versus 0.9%. And that's why, and also a higher rate of reoperation for bleeding, 7% versus 3%. And all the other complication rates were higher with the Ross than with a regular aortic valve replacement. And so the conclusion from this study that perhaps we should rethink the role of the Ross in adults and basically abandon it. Except when you look more carefully at the volumes of Rosses that were done in that study, basically over the 17-year study period, a third of the centers had only done 1 Ross over that 17-year period. 34 centers had done 1 Ross per year, and 9 centers had done an average 5 Rosses per year. So it doesn't matter whether you're doing a Ross, an AVR, a mitral valve repair, whatever you do in heart surgery, when your volumes are this low, it is very difficult to achieve very good safety outcomes. So it became very clear that volume really does matter very much. Since the beginning of my practice, I've focused on reconstructive aortic valve surgery, and we've built a very busy Ross program. And what we've shown is that when you do the Ross on a very irregular basis and you compare the outcomes to aortic valve replacement, there's really no difference in mortality or any major perioperative morbidity in adults undergoing the Ross procedure. So it's really a question of doing this on a regular basis and having the volume to keep the operation safe. So the first thing is the operation can be kept safe. And this is what I mean by high volumes. You see, we started our experience over 10 years ago. And you can see that the volumes have remained high. And this year we're in line to doing over 100 Ross procedures. And these are all comer patients. The average age is 48, 16% are redos, 4% have active endocarditis. But despite all of that, these are the 2 mortalities that we've experienced so far for an operative mortality that compares very favorably to conventional aortic valve replacement, as you can see from the mortality of less than 1%. The third point that's important to remember is that there is a learning curve with the Ross procedure. So it is not an operation that one can just watch a video, wake up one day and say, I'm going to do a Ross procedure on this patient. You really have to study it carefully. You have to plan and prepare for it carefully. And importantly, you have to make sure that you have a team around you that allows you to do these things safely. We also analyzed what the learning curve is with this operation. And you can see here, these are called Q-sum analysis curves. What you see between the 2 red lines is an observed to expected ratio of complications around 1. So anything that remains within these lines means that you're just, similar to what the STS database would predict. If you're above these lines, it means that the risk is higher. And once you drop below these lines, it means that you're actually doing better than the predicted mortality or morbidity from the STS database, which really is what aims for when you have a program like this. And the bottom line was that it takes around 75 cases to get over the learning curve of the Ross procedure. And that's no different than with other operations. If you look at this paper that was published in Circulation 10 years ago, looking at the learning curve with minimally invasive mitral valve surgery, which is another operation that requires some technical expertise, the learning curve was very similar. It was between 75 to 125 cases. And furthermore, more than 1 such operation per week was necessary to maintain good results. So it is important to remember that anytime we're thinking about something like the Ross or valve sparing operations or robotic surgery or anything that requires a bit more or that can be a little bit more challenging, there is a learning curve, and volume is really important. Now, the obvious point is that this is a technically more challenging operation, and there are many technical elements with the Ross procedure that make it not only more demanding from a safety standpoint, but also that translate into better or lesser durability in the long term. So every technical detail with the operation has a direct correlation with how durable the operation is. The benefit we have in 2023 is that we have the benefit of hindsight. What that means is that we are able to now draw lessons from the last 50 years experience with the ROS about the things that work and the things that work less well. And we're now much better able to articulate all the different principles of the operation so that we make it teachable, learnable, and importantly, reproducible. And I can safely attest to the fact or to the notion that this operation can be reproduced, but as we will see later, in high volume centers or reference centers. Schematically, this is what a ROS in today's age would look like in a large number of patients. The pulmonary autograft route is kept very short here on the left side. We use an annuloplasty in a certain number of patients in order to stabilize the aortic annulus. We also put a short Dacron graft just above the autograft in order to further stabilize the sinutubular junction of the autograft. And the pulmonary route is replaced with a cryopreserved, decellularized pulmonary homograft. So I'll show you in a video here what the ROS operation looks like. We use bicaval cannulation so as to drain the right heart perfectly so that there's no rewarming of the heart. And at the same time, because we open the right-sided cavities, it minimizes sucking air into the system. The first step after transecting the aorta is removing the aortic valve, as one would do for any aortic valve replacement operation, and then debriding the aortic annulus. What you see here is a 28-year-old patient who had a very calcified unicuspid aortic valve. So you can see the valve now is removed. And then the next step is to open the pulmonary artery and to examine the pulmonary valve to see whether it is adequate for use or not. In about 1% of the patients, the pulmonary valve will not be usable, either because it has very large fenestrations or because it will be congenitally malformed, such as a bicuspid pulmonary valve. So you see here, we've transected the pulmonary artery. You have to be careful because what you see in the back there is the left main and LAD arteries. So you have to be very careful with that. Then we examine the pulmonary valve, make sure that we have 3 leaflets and that there are no fenestrations or holes in the body of the leaflets. This is a very good pulmonary valve to be used. So before we complete the harvesting of the pulmonary valve, we go back to the left side. We now are mobilizing both coronary arteries, and it's important to be careful when we mobilize the coronaries not to injure the coronaries or to over mobilize the coronaries, especially the right coronary artery that you see here. Anytime you do any root operation, it is very important to minimize how much you're mobilizing the right coronary to avoid any kinks when you come off bypass. I'm sure some of you have experienced right ventricular dysfunction after an aortic root replacement procedure. And often enough, this is a result of how the coronary itself was mobilized at the time of surgery. Now here we're doing a deep dissection around the aortic root. The reason we're doing this is because we're going to add an annuloplasty to this operation. So the annuloplasty, just like a mitral annuloplasty, is a ring that we put, except unlike the mitral rings, this ring here on the aortic side will sit on the outside of the aortic root itself. So we dissect very deep. And then we use this tool here to look at the angles of the commissures to make sure that we have good symmetry inside the root. And then the next step is we'll take sutures that we'll put from inside the LVOT to the outside of the aortic root. And these sutures will be used for the annuloplasty ring implantation. We typically use 6 sutures that go from the inside to the outside. And then we will take a Dacron ring We'll pass the sutures through the ring, we'll lower the ring into position, and we'll tie it around the aortic root. But before we complete the annuloplasty, we're going to harvest that pulmonary valve and measure the diameter of the pulmonary annulus, and this will dictate what size of ring we need, because we don't want to make the aortic annulus too small or too big. So here we're taking a right angle, and we go below the insertion of the pulmonary valve through the right ventricle, through the right ventricular outflow tract. We open the ventricle, and then we, using scissors and bovi, we harvest that pulmonary valve. Again, one has to be very careful where we are right now. There's the first septal artery. We have to be careful not to injure it, and the LAD is to the side. This is what the valve looks like once it's harvested. You can see the leaflets are very thin, and this is autologous. These leaflets will remain alive on the aortic side, and so this is really the main benefit of the operation. Now, in this case, we're using a 32 millimeter Dacron ring because we measured the aortic annulus, the pulmonary annulus at 26 millimeters, and because the ring sits on the outside of the aortic root and there's aortic wall thickness, if you take a 32 millimeter ring, it ends up with an inner diameter of 26. So we tie these sutures around a 26 millimeter Hagar dilator, and now the aortic annulus is exactly the same size as that of the pulmonary annulus. We then pass these sutures across the aortic annulus and through the pulmonary autograft. We like to use single interrupted sutures, as you can see here circumferentially. This allows to ensure that every suture goes in a very precise fashion across the root, but importantly across the pulmonary valve, because we want to exclude that muscle altogether. And what it also allows us to do is that the pulmonary root in systole will be able to expand in a very symmetrical way. You see the sutures here are excluding that muscle altogether. Once the sutures are tied, this is what the pulmonary valve looks like inside the in the aortic position. Then the next step will be to reimplant the coronary arteries, starting with the left main coronary artery here in the back. And then we will reimplant the right coronary artery here in the right coronary sinus. Once the coronaries are reimplanted, then we shift our attention back to the pulmonary side. It is always easier to do this before we close the aortic side. This is a human cadaveric pulmonary valve. It's a decellularized pulmonary root. So you see we do the distal suture line, followed by the proximal suture line. You can see there are many, many different suture lines in this operation, which is why it's important to be meticulous and to take your time to do it. But to be able to do that, one has to protect the heart very carefully. And we can discuss myocardial protection at the end of the presentation, but we typically use del nido cardioplegia for all of our cases. And then the last step here is we use this short Dacron graft, which we anastomose directly to the sinotubular junction of the pulmonary autograft on the proximal end. And then we will cut the autograft, that Dacron graft, very, very short, and anastomose it to the native ascending aorta, just about 1 centimeter distal. The reason we do this is if there's any discrepancy in size between the autograft and the aorta, it prevents any dilatation of the autograft. And you see what the end result looks like with that Dacron graft in between the two. Now, when you do when you follow all of these principles, and when you apply good and careful myocardial protection, these operations can be done safely. And more importantly, these operations can be kept durable. So if you look at this is our inaugural Ross series from the time that I was in Canada. I'd done 450 cases back then. 15% were reduced, 6% had active endocarditis. The operative mortality was those 2 patients. But the important thing is we have very good completeness of follow-up on these patients. So I'll show you what short-term outcomes and long-term outcomes can look like with the ROS when it's done with applying these principles. So this is data that we presented at the ATS a couple of years ago. The average age of the patients in our cohort was 48, with almost half the patients over the age of 50. So these are not just patients in their 20s and 30s. These are really all the patients up to the age of 60 and 65. The majority of the patients had aortic stenosis. 15%, as I said, were reduced, and 6% had active endocarditis. So somewhat all-comer patients. And these were our operative outcomes. We had 2 mortalities. The first case was a patient who had undergone a mechanical aortic valve replacement and then developed endocarditis with root abscess 3 months later. We did an aortic homograft replacement. Unfortunately, she came back 3 months later with large pseudoaneurysms at the proximal suture line. When we performed surgery, everything was very stuck and infected. We attempted a ROS. Unfortunately, she didn't make it past the first 48 hours. And the other patient was a patient who had previous radiation therapy to the chest. She had severe lung and myocardial fibrosis. She needed aortic and mitral surgery, and unfortunately developed a series of complications after the operation and passed suddenly because of cardiac arrest on postoperative day 10. And on the autopsy, we could see very diffuse myocardial fibrosis, which was likely secondary to the radiation disease. So it just, both these cases point to the importance of patient selection when doing the ROS procedure. You don't want to be over-selective. You can still do it safely in patients who are redos or patients who have endocarditis, but you also have to be judicious in selecting patients. And we have learned lessons from these 2 cases. I'm much more careful with patients who have previous radiation therapy, and also more selective in patients who have endocarditis, especially if they have severe root destruction. Outside of that, the risk of perioperative complications is rather low. Re-exploration for bleeding was 2%. One of the benefits is that because of these single interrupted sutures, the absence of pledgets, and the absence of a rigid sewing ring like you see with the tissue and a mechanical valve, the risk of pacemaker is very low. It's less than 1%. If you compare that to a risk of about 2 to 4% with regular surgical valves, or nearly 12% with TAVR, it is much lower and very significant for young patients, because needing a pacemaker, especially in younger people, is associated with a lower survival in the long term. The other big benefit is there's no mismatch in these patients. The hemodynamics are excellent. The mean gradient is always in the single digits, regardless of how small the patient's aortic annulus is. And you can see the mean indexed effective orifice area is very large, and really much larger than one obtains with any type of prosthetic valve. And what about the long-term results? This is our 10-year outcomes. We just presented this 2 weeks ago at the AATS. 10-year outcomes of this initial cohort of 450 patients. And you can see that survival continues to be similar to that of the general population. But importantly, the rate of reintervention is very low in this cohort overall. It is 2% in patients who had aortic stenosis and 1.3% in patients who had aortic valve regurgitation. So very, very low rates of reoperation, which again underlines the idea that following strict technical principles, the operation can be kept very safe and can be made very durable for patients in the long term. So the notion that this is an operation that doesn't last or that is riskier is not quite so accurate, provided it's done at a high volume and following specific principles. But the last point I want to make is the importance of what we call ROS reference centers. And that is to say that all of these operations that we mentioned, whether it's valve sparing, Ross, robotic surgery, etc., they're all more challenging and more complex operations that have very specific, that require very specific skills that are not maybe applicable to everything we do in cardiac surgery. And so it is important for, if we want the Ross procedure to benefit patients, to be done in centers of excellence or reference centers for this operation. And a center of excellence for the Ross is really far more than just a surgeon who knows how to sew circles and to put, move a valve from one place to the next. Of course, it starts with that, but really what it requires is a whole team around the patient, from the nurses to perfusion to intensive care to anesthesia to the surgeon to cardiologists with valve expertise. These are all the elements that are required to be able to safely say that this is a Ross reference center. So a surgeon just coming and saying, I'm going to do this operation, but not preparing the whole team around him and not having a team that fully understands why and how this works and what the principles are, it's just not a great recipe for the long term. And if one had to put some objective measures as to what a reference center should be doing for the Ross, I think there has to be a minimal volume requirement. Somewhere, these are arbitrary numbers that I put there, but I would think somewhere around 20 to 25 cases a year is a minimum requirement to maintain some sort of flow and some sort of expertise. So, a case every other week. Safety, I think operative mortality has to be less than 1%. These are typically young patients, typically young and healthy patients. So there's really no room for increased operative risk. And one also has to follow these patients over time to make sure that whatever we're doing is also durable. And so efficacy is another important point. And if we use a metric at 1 year alone, I think that there has to be a less than 1% risk of reintervention at 1 year after the operation. And we can borrow from the mitral valve space. I think the mitral valve space is about 20 to 30 years ahead of where the aortic valve space should be. Mitral valve repair today, there's no arguing its benefits. There's no arguing that it's that patients do better when they have a mitral valve repair than when they have their mitral valve replaced. And there's also no question about the fact that there are that one has to define mitral valve reference centers, just as the AHA decided to do almost 2 or 3 years ago by defining what is a mitral valve reference center and awarding this designation to centers that meet these criteria, so that ultimately patients know what they're getting themselves into, and they can seek adequate care that is both safe and effective in the long term. So in conclusion, why consider a Ross procedure in adults? I think the Ross can definitely be done with similar operative risk. It can restore late survival for patients. So remember, these are younger people, and our primary goal is really trying to restore life expectancy. If we do things that don't restore life expectancy, we're not serving them as best as we can. And the Ross has better freedom from valve-related complications than a biological or a mechanical valve. Things like endocarditis, stroke, or bleeding are significantly lower with the Ross than with prosthetic aortic valve replacement. It provides better hemodynamics with no patient prosthesis mismatch, which in a 78-year-old may not be so relevant, but in a 38 or a 48 or even a 58-year-old patient who is still very physically active, who spends most of their day moving around and running up and down stairs and traveling and doing things, absence of patient prosthesis mismatch is important from a symptom standpoint, but it's also important from a life expectancy standpoint because it puts a lot less burden on the left ventricle, and less burden and less workload for the left ventricle is equivalent to better survival in the long term. And finally, excellent quality of life. These patients don't need to take any medications. There's no anticoagulation or even aspirin required. And so they live a completely normal life with no restrictions, limitations, or modifications to their lifestyle. But we have to remember that all of this has to be done in ROS centers of excellence or ROS reference centers, because this is what ensures that these operations can be done safely and effectively. So with that, I would like to thank you for the opportunity to be with you today. I hope this was instructive. I hope you learned something from this presentation, and I'm not sure if there is room for questions, but I'll be happy to take any questions from the audience. Great. So I see a question here that says, would you please tell us how a perfusionist can help you making the surgery more smooth? So that's an excellent point. So there are a number of things that are very relevant here from a perfusionist standpoint, because first of all, when we do a ROS, we have to go to the right side. So drainage is really important, because if the drainage is not adequate, it makes harvesting the pulmonary autograft much more challenging. And also what it does is because the RV is open, if the drainage is not good, we get immediately flooded with dark blood into the field, as opposed to, the heart filling up. So drainage is really important. We always discuss with the perfusionist the size of cannulas that we're going to implant. I like to use bicaval cannulation in these cases to make sure that we're really very well drained. We want to use the largest venous cannulas possible without being too bulky for our surgical field, but the largest possible that allow us to work comfortably. Typically, we use a 24 or a 28 venous cannula for the SVC, and a 28 or a 32 venous cannula for the IVC. Occasionally, we'll use a 36 cannula for the IVC if the patient is very large. That's one. Secondly, it's myocardial protection is also a key for this operation. Whether one is using blood cardioplegia or a del nido cardioplegia. For the first 5 years of practice, I was using blood cardioplegia, and it's important to be very much in sync. I think when the perfusionist understands what we're doing, ideally, if there's a camera on the field that shows what we're doing, then the timing of blood cardioplegia can be done hand in hand. In other words, if we want to give blood cardioplegia every 20 minutes, but you see that at 18 minutes we're tying sutures, or we're doing something where you can quickly squeeze in 3, 4, 5 minutes of blood cardioplegia, an interactive perfusionist who's very much in touch with what we're doing will be very helpful, rather than just waiting for the 20-minute signal. So that's one thing. And same thing with del nido. We typically redose every 60 to 70 minutes, but sometimes we'll do it a little sooner, sometimes a little longer. So it's always good to get a bit of a heads up at 45 or 50 minutes that this is where we're at with the cardioplegia. And this way we can redose at a time that we think is more convenient from a surgical flow standpoint. So these are some of the things. Of course, maintaining adequate perfusion, a good hematocrit, making sure that the perfusion pressures are good, not diluting the patient too much, and not giving too much volume during the case. All of these things are also very helpful in order to maintain good urine output, good kidney function, and also, importantly, good hemostasis at the end of the operation. So I think these are some of the points that where a good collaboration with perfusionists are important. From our standpoint as surgeons, one thing that we have to definitely do is to make sure that we communicate with the perfusionist. Ideally, if we have a video, then they can easily see what we're doing. and that really helps the perfusionist be able to work hand in hand. Otherwise, we have to communicate on a constant basis where we're at, what we're doing, and what we need, so that we keep things very safe and stable. I see a question about the Del Nido protocol. So the Del Nido, we give the initial induction dose, we give 4:1 Del Nido in blood. The induction dose, we give 1,500 cc's. I use that systematically, regardless of patient size or BSA or BMI or size of the ventricle or size of the heart. However, the induction dose, I always give it only antegrade. I do not rely on retrograde Del Nido cardioplegia, just because with the retrograde catheter, you're just not too sure how well you're protecting the right heart. And therefore, in any patient who has even a mild aortic regurgitation on the preoperative TEE, I will not give Del Nido through the aortic route, because you don't know how much is actually being delivered to the heart. And so what we do is, after we clamp the aorta, I'll put the LV vent, I'll transect the ascending aorta, and then I use two selective cardioplegia cannulas. We typically use a 6mm cannula and a 4mm cannula, the 6mm for the left main and the 4mm for the right coronary. This way we give more flow to the left side than to the right side. I give it simultaneously. We aim for a pressure, a line pressure of 200 millimeters of mercury on the perfusionist side. So the perfusionist will tell me what the pressure is. We shoot for 200 pressure. And typically with 200 pressure, I expect a flow of around 200 cc's per minute, give or take. If I have less flow than 200 cc's a minute, then I have to troubleshoot from my end. It means that either my selective cardioplegia cannula is sitting against the wall of the RCA or the left main. It means that I might be over selective on the left side. I may have pushed the cannula too far, and we're only delivering down the LAD or down the circumflex. So the flow is the correlation between flow and pressure is really important, and it's something that we pay a lot of attention to in our OR anytime we do this. The perfusionists know that 200 is our pressure limit, and they always communicate how much flow, and any variation in flow is something that we will act on very carefully. And then we redose every 60 to 70 minutes, never beyond 70 minutes. Even if you think you're going to finish the operation and take the clamp off at 80 minutes, it is really important not to try to cheat or to stretch it, because I think that's how you can run into trouble with Del Nido. And the redosing volume is around half of the original dose. So we give 700 cc's, again, using the same protocol of selective antegrade cardioplegia delivery. I think these are really important points with the Del Nido cardioplegia. If you're using blood cardioplegia, then you can do it every 20 minutes. You can do it with antegrade or retrograde. Really, the main principle is to keep the heart continuously as cold as possible and perfused. But with Del Nido, it's really important that it be antegrade and always so that you know that everything's been delivered and that you're not skipping any territories, because you're not continuously perfusing. So that one shot is really what the heart depends on, and therefore it has to be a perfect delivery. With regards to temperature management, we typically only cool down to 34 degrees systemic. If for whatever reason I feel that our drainage is not very good, or that this will be a much longer typical clamp time for a ROS are somewhere around 2.5 hours. If it's a redo, if there are concomitant procedures to be done, or if it's a more technically challenging one, it can go up to 3 hours and sometimes even more. So that means that the bypass time is typically around closer to 3 hours. So, you know, we have to be sure that that we get adequate perfusion for the rest of the body, and that. But if the drainage is not very good and the perfusionist has to overflow and we get flooded and we tell them to go down a little on their flows and the pressures go down a little, if anything happens like that, then we'll take the temperature down to 32 degrees. But otherwise, 34 degrees is usually perfectly adequate. Great. I see no more questions. Once again, thank you so much for the invitation and the opportunity to be with you this morning, and I hope to meet some of you in person in the near future. Have a great day and enjoy the rest of the meeting.